So the purpose of this recording is to put the video on the YouTube so that trainees could learn, and those who could not attend. So I thought that I wanted to share something interesting. I just finished listening to this book. It's a beautiful book. It's called 168 Hours. It's actually 7 days, 24 hours. That's 168 hours. And it talks about how, we think that we don't have much time, but it actually talks about how you have more time than you actually think. It's a fascinating book. I wanted to share that if anybody wants to listen to this book, and you will be surprised how much time we actually waste. Mm-hmm. All right. I want to thank everybody who has joined today, and I want to thank Sylvia, and Sriram and Roy, who have been helping with this weekly Zoom class. And I want to thank my mentor, John Stroline, Mr. Charles Butt for the grant, Angela Deal, who produces these beautiful illustrations, and my university for helping me with these Zoom classes and able to put them onto the YouTube. So this is an interesting problem, a complex problem, and I wanted to share the story and not just talk about the EMR, but the patient as a whole. So this is a gentleman in his 70s who was referred to me for EMR, and I performed the EMR about a couple of weeks ago. And I want to take you through his story. His past medical history was significant for diffuse large B-cell lymphoma, which was diagnosed 10 years ago and treated. And I'll go through whatever treatments he has had so far. And as far as the lymphoma is concerned, no residual disease. He also has a history of atrial fibrillation and cardiac function with an ejection fraction of 52%, and chronic kidney disease stage 4, and duodenal adenoma. So his only antithrombotic medication is aspirin. So this is how the story actually goes. So he was in good health, came in with B symptoms and weight loss. And at that time, he was found to have a B-cell lymphoma. And he was treated in 2010 with a rituximab and CHOP regimen. And then he was put on R-ICE. To be honest with you, I couldn't figure out what R-ICE is. Selvi, do you have any idea?
No, Raju, we'd have to look in the chart and try to figure it out.
Maybe it's
not off the top of my head.
Then he went through stem cell transplant, went into complete remission in 2012. Following that, he was entered into a trial. And then from 2016 to 2017, he was on rituximab and lenalidomide. And in 2017, he was on this obinutuzumab. These are all medications that are used for lymphoma. They basically work on the CD20 molecule antagonist, and he was negative, right? And as far as the lymphoma is concerned, he has no issues at all. That is really remarkable. And as for his follow-up, he had a PET scan done in 2019, and the PET scan showed a bright area in the duodenum, right? And interestingly, he had a similar light up of the duodenum a year before, but at that time, the radiologist thought that it was a physiologic signal rather than a lymphoma signal. Because if you actually go through all his PET scans, he had several areas that lit up in the past, and then they basically disappeared. And this is something new, but they thought it was physiologic. But as it persisted for the following year, they decided to have an upper endoscopy. It's also interesting to note that he's in his 70s, has never had a screening colonoscopy. He's African American and never had a screening colonoscopy. So he had an EGD, and as you can see the diagram, one is the pylorus. You're entering into the second portion of the duodenum, and you see a large circumferential tubular villus adenoma with focal high-grade dysplasia. It's total circumferential involvement. So Selvi, any comments on this, given the fact that you see a lot of adenomas in your practice as an FA for follow-up of FAP patients?
Sure, Raju. This is a very large plaque in the second portion of the duodenum. We see these more often in the context of patients who have FAP or pathogenic mutation in the APC gene. It is possible to see it sporadically in patients who do not have this genetic mutation, but much, much less common, certainly. I know that these are in FAP patients and in other patients very indolent or slow growing. They don't very often turn into cancer, but they do require surveillance. There's the Spiegelman staging that we use for patients with FAP to classify these duodenal adenomas to see how often we need to do surveillance or if there's any other features that would require more aggressive therapy than just surveillance. So if it showed high-grade dysplasia, I think there is in our PATH conference, in our pathology conference that we have every week at MD Anderson, our GI pathologists have said that sometimes there can be a little bit of discrepancy in terms of when there's a tubulovillous adenoma, knowing that the normal histologic pattern of the duodenal mucosa is villous architecture, whether this is a villous, truly a tubulovillous adenoma or just an adenoma on a villous structure. So it would make sense to repeat the upper endoscopy and do more biopsies and see if there can be a consensus of what the findings are. That's in terms of the tubulovillous adenoma. If there is high-grade dysplasia, again, you would either have those biopsies re-reviewed or do another endoscopy and take more sampling to see if there's truly high-grade dysplasia. If there is, then I think, at least a surgical consult with a pancreatobiliary surgeon would be indicated. The other important thing, I don't want to go on too long, Sylvia may want to weigh in, but another important thing is to see if there's involvement of the ampulla, because that certainly has implications for surgery for this patient. Some of these villous adenomas can grow into the bile duct through the ampulla if the ampulla is involved. So that's another important consideration. We've seen patients with that at MD Anderson. And I don't see where they used to cap on this procedure on the end of their scope, or if there is, I don't see it in the images that are included, but using a cap will really allow you to examine the ampulla itself and see if there is adenomatous involvement of that area or not. Whether this can be the reason why the PET scan was positive, I will defer to, maybe you'll talk about that later in the presentation.
Okay.
I'll stop here. I know I've said a lot here.
All right, thank you. I think it's good. I think one of the important things for the fellows to keep in mind is whenever you see a duodenal adenoma, you have to think, is this just the duodenum or duodenum plus ampulla? Because it makes a big difference in the management of those lesions. So at the same time, a colonoscopy was done. This was the first screening colonoscopy at age in the 70s. And as you can see here, I want you to focus on the images 6, 7, 8. And the findings were described as a lesion in opposite the ileocecal valve. I'm hoping that the ileocecal valve was here, a large flat lesion, about 3 centimeters, draping a fold. And I'm hoping that this is the appendix. I think it looks like that's the appendix. All right. You agree with that? Okay. So the pathology of the duodenal mass was a tubular acidoma with high-grade dysplasia, and a large flat lesion was not biopsied, and a few small polyps, which were tubular adenomas and tubular adenomas. And I want to take you through what happened with this patient. This procedure was done sometime in July, in the midst of the COVID, and they wanted to have a surgical consult. They did have a surgical consult for the duodenal mass, and as part of the consultation, I didn't put here the MRI, MRCP. MRCP was done, which showed that there was no mass. The mass was limited to the duodenum, nothing going beyond the duodenum. And the pancreatic duct and the bile duct were prominent. So you can take thinking that maybe there's an ample involvement. I wish that we did a side vein scope exam to really figure out. But as part of the multidisciplinary conference, what they felt was he's not a candidate for surgery. Probably, I don't think our interventional group, endoscopy group, looked at it. My suspicion is when you have a circumferential involvement, large area in a 70-year-old plus who has chronic kidney disease, stage 4, resection would also be not that easy with a high risk of bleeding and other things. So although that was not decided, the multidisciplinary meeting, the surgeons and oncologists felt that not a candidate for surgery, let's get a geriatric evaluation to look at his life expectancy. I think it's a good idea to do that. If the life expectancy is short, then you would leave it alone. If the life expectancy is long, several years, then maybe look back at what is risk for surgery and then decide whether surgery should be done. So he's undergoing a geriatric evaluation as we speak. And they also recommended to repeat EGD in 3 months. So that's where we are as far as the duodenal lesion is concerned. So I saw him this month. And actually, it's very interesting. We did a video visit, unlike the virtual visit, because he didn't want to come in. And so whenever I'm actually doing a procedure, I actually look at this pictures with the team and review the findings before we start the procedure. Something important for the trainees, it's good to have your whole team look at what you're trying to do so that they can prepare better. And we're thinking that, okay, this is a lesion in the cecum opposite the ileocecal valve. Pretty easy to find out and go ahead and do the resection. And I was thinking that, okay, we are dealing with a laterally spreading non-granular tumor draping over a fold. So in this case, a cecum, thin, risk of perforation, especially when a polyp is draping over a fold. Those are the ones that the Japanese have commented are at higher risk for perforation if they undergo ESD or whatever. It is also true when you're doing an EMR, if you don't direct your snare parallel to the wall and you cut across, you're going to have a perforation. So I would let Sylvia and Sriram comment on this. Okay, this is the ileocecal valve, and then I want to play this video. And as we play the video, maybe one of you could comment on this.
That's clear. It's better now.
So Sylvia, what do you think?
So I think that in this picture at about 3-4 o'clock, we see a second lesion. So on the right side of the appendiceal orifice, there is a second laterally spreading tumor. In white light, I cannot see the whole contour of the lesion. The borders are not very clearly delineated, but it looks to be a laterally spreading tumor, non-granular, flat, elevated subtype. So actually similar to the first you have described. And I would use image-enhanced endoscopy to better characterize the lesion. Actually, at the first sight, I don't see any signs of submucosal invasion. There is no fold convergence, there is no expansion, there is no wall, misformed wall or things like that. And it looks to be a benign lesion. So I would further characterize it at this point.
Sriram.
I agree with the previous comment. It looks like almost like a asymmetric dumbbell-shaped lesion, a flat lesion. I think image enhancing with either NBI or chromoscopy might define it much better. It does look larger than what it initially appeared as one single polyp. It is a single polyp, but it is extending in a atypical shape.
Yeah, actually, I want to share with you something. I was a little bit, you see this lesion here, right?
Yes.
And do you think they're the same?
Yeah, that's what I was wondering right now. It looks like this is a different lesion for two reasons. One is that the distance between the appendix and this lesion is much shorter than what it appeared earlier. Of course, unless you come back to the IC valve and look at the opposite side and see the original, bring back the original configuration in your vision, and then reproduce this might be the only way.
So actually, I was totally bummed out, to be honest with you, when I was doing this patient. I actually looked at it for almost 10-15 minutes, trying to convince myself this is the same lesion. And then I examined the whole cecum up and down, as you can see. And I cut off some of the video because I didn't want to waste your time. And I examined it so many times, and I could only see this lesion. I wondered, would a lesion change with time? We only know that the lesions grow unless I'm looking at something totally different.
But the morphology, the surface morphology appears to be slightly different on this one compared to the original that you showed. So that may be, hindsight is 20/20, of course, but that may be one of the things to just remind ourselves the way the appearance is. If you look at the first image that you projected, it has more lobulations on the surface, and this one looks more, look at that image 5, or so the more lobulations on it compared to more flatter the lesion
so if you look at it,
described.
This is where the appendix is, right? This is not like a fully distended, and this is the lateral wall. This is where the ileocecal valve is. And if I look at this, so that whole lateral wall, you're seeing it multiple times. So anyhow.
Raju, can I ask a question? So what was the time lapse between the colonoscopy that was done where they referred you the patient and when you 6 months?
Yeah.
And what kind of treatment did the patient have in those 6 months for his lymphoma or?
So
Did
that
he got some chemotherapy or some immune
no
therapy or something?
chemotherapy. I think he was on one of those monoclonal antibody treatments.
Okay.
Right. That's the only thing. I was actually wondering whether I should go back to the oncologist and show him and say, hey, is there an impact from one of the treatments that
Right.
you do to have anything? I actually wondered about
That's
that,
my question.
but I
Yeah.
wanted to see that I'm not imagining something. And I actually, it's very interesting. I stopped the case. I went back to the images again and looked at it. And I said, okay, this sentence doesn't look, but I examined it maybe 15, almost 10, 15 minutes, including putting underwater to decompress the cecum so that you can see the walls. And so anyhow, whatever it is, I think, all right, let's move on with our own case and then we'll get back to you and let you know what happened. Okay.
Well, but there is a very important point that you described. I think that needs to be re-emphasized, that don't believe your eyes and keep reconfirming and make all efforts to make sure that we are not missing a large lesion. And that means to doubt oneself is very important in these situations, which you highlighted. Thank you.
Yeah, that's actually is very interesting. When I saw this, I actually, I went through quite a bit of mental struggle to figure out, okay, I'm cutting the right one, or am I picking up a new lesion? Okay. And next week, I'm going to tell you a different story of the same patient, which actually I will present as we go on. So Sylvia, what do you think about the lesion now that you have NBI?
I think at this point, I would really prefer to use indigo carmine. Why? Because in my experience, patients who have two laterally spreading tumors, especially in this context, when you suspect a polyposis syndrome on the background, I think they might have even more lesions. So to maximize the output of the examination and to make sure that I don't leave another LSD behind, I would prefer to selectively use indigo carmine 0.3% and to examine at least the right colon, do pancolonic in the right colon.
Okay, that's a good point. I think so. That's what we'll be doing later on. So, what do you think about this lesion in terms of your prediction of histopathology?
I think that it's an adenoma. It's a benign adenoma in terms of predicted histology. Because when you used the NBI, it was clear to me the tubular pattern and the regular vascular pattern surrounding the tubular structures. So I think it's most likely an adenoma.
Okay. So we decided to inject and cut, and we used saline with methylene blue. I didn't use any epinephrine. And I thought that, okay, this is not a big lesion. We may be able to cut it in one piece. And we started injecting. As you can see, we are using a little bit of a tap on the syringe plunger to get a nice lift. As you can see, we try to inject at one place and get a nice big bleb or submucosal bleb, not the mucosal bleb. And as we inject, we try to move the needle back to give ourselves some space. And so you can see that we got a pretty good lift. But I thought that I should inject a little more on the right side, especially at the top. So we injected a little more so that we can get a little bit of a better lift. So in terms of your cut, let me ask Sriram, how are you going to cut this one, Sriram? What is your snare preference? What's your cut preference?
I just don't change my practice. Just only thing is that because of the nature of the lesion and the good lift that I obtained, I would use a hot snare and take it in one single piece if I can.
Okay. And what size snare would you pick up for this one?
I think 15 millimeters should be good enough.
Okay. And what is your snare
Because
preference in terms of the manufacturer?
For any size like 15 millimeters or a little more, I tend to use, there is a snare called eye snare or an injection snare from Steris, previously US Endoscopy. It has both needle as well as a snare. So it makes less number of change of accessories. But in practice, I don't think if you have a good access, snare probably doesn't matter too much.
Okay. All right. So we used EndoCut Q, effect 3, duration 1, interval 3. And initially I thought that I will be able to cut this thing unblocked, right? So you can see that I'm trying to put my snare, and the snare actually became almost vertical. And my position was not good to flip to the right, right? So I decided to come to the right side and change my plan. And then as I was thinking about getting this, because at the top, there is a little bit of a depression here. Not a depression, it didn't lift as much as this one. And when you try to close the snare, what happens is this left arc of the snare is going to slip. So I decided that, okay, maybe I should not try to get that one in one piece. Instead, try to cut it in 2 pieces. Because this lesion looks like a Y-shaped lesion. So you can cut one limb and then cut the second limb. So that's the game plan. That's why I basically said, okay, let's cut this one in one piece. So you can see that we are able to grasp that and able to cut. And as you can see, there is nice clean submucosa. And then we decided to apply the snare on the left side. And this video, basically, I did not edit any portion out. I just wanted to show you the whole thing from the beginning to the end, even the futzing around that happens. That way, at least you get a feel for what happens during a procedure, even if somebody has a lot of experience doing this. So then if you look at it, there is a little bit of tissue here, right? There's a little bit of tissue here. And that is the one that's going to create recurrence, and you want to cut it. So we started the procedure with a 15 millimeter snare. We cut the right half, then we cut the left half, and then we are trying to get that small portion. 15 millimeter snare is not the best option for this, but we wanted to avoid using another snare for that. And as you can see, we are trying to do that and it slips. And you can keep on trying, or you say, okay, let's try one more time. And if it works, it's good. If it doesn't work, then you have to change and do something else. And as you can see, again, right? So at this stage, you have 2 options. One is you can get another smaller cold snare, or use a hot biopsy. And I use the hot biopsy forceps. And for people who have not done the hot biopsy avulsion, what you do is you get the polyp tissue and pull back and apply the tension. And you have to change your settings from EndoCut Q to I. So I used EndoCut I. I changed the effect to 1, because you want a pure cut. And then duration, I put it as 3 or 4. And interval, usually I keep it at 1. And we got a nice clean edge. So Sriram, any thoughts on that?
Well, there are different ways to skin the cat.
Right. It's good for people to
Yeah.
Learn that.
Yeah.
Our goal is, most important thing is for people to appreciate there are so many different ways of doing the job. So what would you
Yeah.
do, or what would you have
Yeah.
done in this case? And maybe I want to hear Selvi and Sylvia as well. So Sriram.
Some of these Snare snares come with 3 different sizes in the same snare, and they're hexagonal. So you could open it at different lengths. So that is one way to take out that small segments. Otherwise, my first preference would be to take a cold snare and either Boston Scientific 10 millimeter cold snare or the US Endoscopy cold snare, Exacto, and try to get those things, those 2 small pieces, and then cauterize the margins. Of course, it requires a change of accessories, etc. Whereas in your approach with the hard biopsy forceps, you could actually use the tip of the hard biopsy for soft coagulation of the margins. So that is another way to reduce the number of exchanges and speed up the process.
I think I'm glad that you brought it up because it's very important for people to appreciate, because sometimes what happens is as we do cases, we are stuck in one mode, right? Whatever mode that we practice, and it's good for us to think outside the box by listening to others, how they do it. I like that idea. Okay.
And also it is more easier to do margin soft coagulation of the margin with either a tip of a hot biopsy forceps or a coagrasper than with the tip of the snare, where the control may or may not be real good with the assistant. So this one, you don't even have to open it, just put it by the side and apply the soft coagulation. So in that sense, this has a little advantage. On the other hand, the cold snares, if you select an Exacto, you cannot use the same snare for soft coagulation because it is a cold snare. Whereas the Boston Scientific cold snare, Boston Scientific 10 millimeter captivator 2, if that is what one uses for using cold snare, but that also can take a heat, so you can finish with the cold snaring and complete the tip coagulation. Or if you are having trouble with cold snare or you don't want to do cold snare, you could still do hot snare with that one.
Okay, that's good.
May I have a comment?
Yeah, please.
I just wanted to comment on your choice to resect piecemeal this lesion, and I think that was a very good illustration. In this case, this patient has a lot of comorbidities, and the lesion is on the cecum pole, so we should go for safety. So a laterally spreading tumor on the other hand side of non-granular flat elevated type has about 1 to 5% risk to contain submucosal invasion, so very low. So matching these 2 categories of factors, patient risk factors with lesion associated, lesion related risk factors, I think that piecemeal resection is a very good option in this case. So we are going for safety. If a complication happens in this case, the patient will not have so many resources to recover. So that's why we should be cautious in our choices to resect such lesions.
That is such an important comment that you made, Sylvie. It is really important for people to recognize this differentiation between what you can do versus what is needed for the particular situation in which, or the patient in whom you are operating. And if I remember right, this patient also has background history of chronic kidney disease, which increases, I'm sure the vascular atherosclerotic complications will be higher. So bleeding complications will also be kept in mind. So I fully agree, especially the nature of the lesion also being like it's like a snowman with the in the hourglass shape. The top half is smaller and to in a different direction, and the bottom half is more wider, there is always a chance of not being able to grasp it in one go. And once you start polypectomy, and if you're not able, if you are skipping the margins, then you haven't achieved anything for the risk that you have taken. So that kind of a risk mitigation thinking all the time is cannot be overemphasized.
Thank you. Thank you. Thank you, Sriram. Thank you, Sylvia. Selvi.
Raju, I was going to make the same point that Sylvia made, which is the fact that if you're confident in your ability to do an optical diagnosis of the lesion before you resect it, using either, using chromoendoscopy, electronic or mechanical, then you don't need to worry about removing it in one piece.
Yeah.
One more point I wanted to make
You
is
can afford to do piecemeal as long as closely, then that should be fine. But I agree with all the comments that were said before. Thank you.
I apologize. There was a delay, so there was I was over talking on the previous comment. I apologize for that. But the point I was trying to make, the extra point I was trying to make, is that considering all his background with an ongoing lymphoma treatment, a background of kidney disease, being 70, has a large polyp in the duodenum, even if our approach to this particular polyp is a little compromised, I don't think this patient is likely to exit through colon cancer of this polyp, or the consequences of residual polyp from this, compared to the other factors that could get him. So that also has to be kept in mind in our decision making to adjust our risk, how much risk we are taking versus what benefits we are giving him.
That's good. I think what I would like to make one comment to the trainees, that is, in terms, once you think that the polyp is benign from the endoscopy features that Sylvia outlined, then you shouldn't worry about whether you get it en bloc. If you can get it en bloc safely, that's great. But what matters is, as long as you cut and you don't see any residual polyp left behind, you will have very, very low recurrence or almost close to zero recurrence. If you think that, okay, I'm going to resect so that I only see submucosa and my edge looks clean without any macroscopic disease, and if I go ahead and ablate the edge, with that, you can be assured about having almost close to zero recurrence. So something to keep in mind. Okay, so we went ahead, as part of my practice, I use APC, and we used, and I use the same settings for APC. I use about 35 watts. I used a forward jet APC and 0.8 liter flow. And it's a forced APC, not the pulsed APC. That's what I've been using for the last 10 years. And so it works for me. You could also try pulsed APC or a precise APC when your target is moving and you're not able to maintain the distance. So there are different ways of doing it. But one thing I try to do is I want to make sure that my ablated area looks brown, so that if there are cells there at the edge, you can be assured that you have actually destroyed them. When you do APC, and if you do it very lightly, you will have a little bit of whitening. I'm not sure that that whitening will go deep enough to destroy the cells in the deeper part of the mucosa. But you have to keep in mind that you have enough submucosal saline still left before you do this. And the other thing is you have to keep in mind that you can actually close the defect so that you could avoid any delayed perforation. So So we did the APC, and I want to show you how we close the defect. I was a little bit worried as we discussed, he's a gentleman in his late 70s actually, and he has a lesion on the cecum that we resected. He has underlying kidney disease and hypertension. His kidney disease was stage 4. So all of those are risk factors for delayed bleeding. So we don't worry about, we know for sure that clip closure has been shown to reduce delayed bleeding, especially in the right side of the colon. And if the patients are on anticoagulants, it's been shown to be beneficial. So when it comes to closing, it's very important to create deep approximation, because if you look at the anatomy of the submucosa, the bigger vessels are in just above the muscle, a few micrometers above the muscle, and you want to get a deep approximation. How do you know whether you got a deep approximation? You should not see any gap in between the clips, the blades of the clip. And the second thing is, one trick I want to share with you is, as the assistant is closing, you need to push your clip by a couple of millimeters, because the jaws of the clip retract whenever you close. So I suggest that next time when you open up a clip, you put your finger at the tip of the clip, open clip, and then you close. You will see how much the jaws retract. So you have to compensate for that by either pushing the clip or pushing your scope so that you get a deep approximation. As you can see here, we got a deep approximation. Every time I close, I always want to check by taking a photograph on both sides to make sure that I've actually approximated mucosa to mucosa. And the gap in between the clips is probably less than a couple of millimeters. And that is what you should accomplish to cut down the risk of delayed bleeding. There is a very beautiful study from Spain where they've shown that if you close the defect with clips, partial versus complete closure, or they call it as incomplete versus complete closure. Complete closure has, as we can anticipate about the benefits. Complete closure is the way to go to get the benefit from clip closure. So any comments, Sriram, Sylvia?
Maybe some general comments about the case, but maybe in the end, I don't know if someone else has specific comments at this point.
Just a quick one is that before closure, as a matter of practice, to examine the defect closely to see if there are any exposed vessels that need any additional treatment before we actually close the clips. Just in case, if there is a little more gap between the clips than what you anticipated, and if that exposed vessel happens to be in that gap, then the subsequent post-pulpectomy bleeding treatment of that will be a little annoyance. Of course, you can place another clip, but that's just to make it a good practice to look at the defect site for looking for vessels that you could soft coag right in the beginning.
Right, that's good. Shelby?
Beautiful job, Raju. I just always remember, even when I'm doing, clip closure myself on my patients, that when you said in one of the previous Zoom sessions, you want as much approximation of tissue within the jaws of the clip as possible. If there is a gap between where the clip ends and where the tissue begins, then it's just for cosmetic purposes, and we don't put clips on for cosmetic purposes. So I always hear your voice in my head when I'm putting clips in. This is a beautiful job as always.
Nice.
Right. So it's actually, the case doesn't end here.
May I have one more comment, a general comment, maybe not so much applicable to this patient who's a frail patient, 70 plus, and with a lot of comorbid conditions. But if I would have found in the descending part of the duodenum such laterally spreading tumor, circumferential, I would have thought that the patient could have similar lesions in his small bowel, deeper in the small bowel. So I recall that an MRCP has been done, but I don't know whether you have used contrast.
I don't think, because of his kidney disease.
Okay, oh, that's correct. So what I would have done, but again, not in a fragile patient, I would have taken the longest colonoscope that I have, and I would have inspected the small bowel as far as I could. It happened to find a couple of times similar lesions in the small bowel, and to better phenotype the case prior to genetic diagnosis. And again, we should ask ourselves, is genetic diagnosis in such a case necessary? As Selvi pointed out, we may think to an attenuated FAP, but maybe in my opinion, it's more likely to be a multi-age associated polyposis because of the older age. Anyway, if for this patient, it might not be so relevant, he might have family members who are mutation carriers and who might benefit from screening and surveillance. So the answer is yes, I would perform further genetic investigation in this case. That was my point.
What do you think about capsule endoscopy in such situations?
Yes, in patients with Lynch syndrome, we had a randomized control trial whether video capsule can help to diagnose pathology of the small bowel, and it didn't appear to be helpful. Because the prevalence of colorectal neoplasms in the small bowel is very low in this patient, it was not effective to perform screening and surveillance. So if such a patient would have a family member with small bowel carcinoma, yes, I would try to make sure that the whole small bowel has been examined. I would use a video capsule. If this would be positive, I would use a double balloon colonoscopy, but not in such a frail patient.
Thank you. Thank you. So I want to show you something actually. So we finished the closure, and so we're coming back and we see this another lesion. Okay, this is actually in the proximal ascending colon beyond the IC valve. And it's interesting that to hear Sylvia comment on doing a chroma endoscopy to find out about other lesions. And this lesion doesn't look like the original lesion that we were asked to cut, right? This is a granular tumor. It's not a non-granular tumor. And this was very hard to really find out, actually. I could have easily missed if I didn't have the cap. So we're going to talk about this next week because this is interesting learning material.
Thanks a lot.
All right, we can open this one for any questions. If anyone has any questions, feel free to ask.
Well, while you're waiting for comments, I have one more comment to make. So, Sylvia talked about the voice in the head. And I think the value of this weekly meeting is to develop that voice in the head. For all these, every session that you're showing one particular different kinds of aspects of the the same procedure time and again, but that is the reason that is the basis on which people can develop the voice in the head about what I'm seeing now in my practice, what they would have done or what Dr. Raju would have done. That kind of a thinking, I think, helps in improving our quality of our day-to-day procedures for all of us. And that's the importance of voice in the head. And maybe you can change the title of your meeting to voice in the head.
Oh, Sriram, thank you. Actually, it's interesting that you make the comment. There are two components to endoscopy. One component is the cognitive aspects of endoscopy. We all think endoscopy, most of the senior gastroenterologists who have done a lot of work by just being gastroenterologists and not endoscopy, think that endoscopy is more of a technician's job. In order to really do a good job, you have to think through the problem and figure out what's the right approach. That's the cognitive aspect of endoscopy. And then the technical aspect of endoscopy is, from the mind to delivering the care with your hands, right? I feel that I cannot train people in the technical aspect of endoscopy by holding their hand. We all have a very limited amount of resources to do that. But at the same time, we can actually share what goes on in our head, and by being open and say, put all the cards on the table, what you did right, what you didn't do right. And if you can share that, maybe people can learn better. And then they could apply some of those principles in their own practice.
I fully agree. In fact, what is the big deal about the technique aspect of it? It is the understanding and comprehension of why, what, how is more important than actually anyone can put a snare and apply cautery, but it is important to know how to put the snare in each different situations and how to change the settings, that if at all you need to change the settings. Those are the important aspects that one develops with time and effort. And this meeting actually helps in people developing that kind of a comprehension aspect of it. And one more comment I have, one more take-home lesson from me in this particular meeting today is your comment about discussing, if you know that there is a lesion to be resected today, to open it up and have everybody in the room, whoever is involved in the procedure, to be educated about what the lesion looks like and what plan you have in mind at this time, which is subjected to change, of course. But that, I think the other benefit of it is that you're investing in their education, and also from the respect that you are showing to the associates and the technicians and the nurse, will increase their participation and their willingness to go with you in a longer procedure or whatever, because now they are part of the management of the polyp and not just hang-ons there that they're assisting for the big guy who is performing. So it increases participation. I think it improves the morale also. Thank you very much for making that comment.
Sylvia.
Thanks a lot. It's been a very, very instructive case. And I'm very curious about secondo tempo.
Thank you. So, Sylvia, we need to make sure that we look at this pathology this Wednesday.
Okay, Raju.
I put it in there. I hope.
I hope if they have the slides, we'll look at it for sure.
Yeah, because
Dr. Raju?
It blew me out. Yeah, please.
So I'm Ammar, I'm Advanced Endoscopy Fellow. I have a quick question about using a coagulation biopsy forceps to control the bleeding versus the tip of the snare at the base of the polypectomy. Is there any risk of post-polypectomy syndrome with the tip of the snare compared to the coagulation grasper?
I'm sorry, I didn't hear your name.
Sorry, Ammar. I'm Advanced Endoscopy Fellow from
Where are
Western
you based?
University.
Amar, where are you?
Canada, Western University.
Okay, so repeat that question.
So I want to ask about the coagulation grasper versus the tip of the snare to control the bleeding at the base of the polypectomy. Did
Okay.
you notice any difference between both?
No, actually, okay, I want to share something very important. Do you use Irby?
And not that frequent. We use the ARB sometimes, and it depends on the hospital that we are working in. Some hospital has ARB, so we use the soft coagulation mode.
Okay, so let me comment this because it's very interesting, and I actually changed my practice only just in the last year or so. So when you look at the Irby machine, on the left side you have the yellow zone, and the right side you have the blue zone, right? Yellow is for cut and blue is for coagulation. And the yellow, you set up the endocut, Q313 or whatever. And then the blue is always left as forced coagulation, right? And when you're using your Irby machine, when I started, the practice that I changed was I keep my endocut Q settings on the left, and I'm changing my blue settings from forced to soft coagulation, effect for about 65 or 80 watts. And I set it out there at the beginning of the case. So say, for example, you cut a polyp with a snare and you have a small capillary ooze or a small vessel bleed, you can use the soft coagulation, the snare tip, and you don't have to even do anything, right? You already set up soft coagulation on your machine, and you touch on the blue pedal and it will coagulate. So that's one thing to keep in mind. The reason is I say that you changed from forced to soft at the beginning of your case is you would not have to waste time to change your settings. So that's one. In terms of the blood vessel, size of the blood vessel, and the effectiveness of a snare tip versus a coag grasper, the snare tip works for most, but if it is a bigger vessel, it may not be able to control the bleed, in which case you may have to bring the coag grasper. For most EMRs, like flat lesions with EMRs, right, which are not bulky, with a large sessile component. So in those cases, flat lesions, not sessile, when you do EMR, you should be able to control the bleeding with your snare tip. But when you're cutting a bulky tumor, which is likely to have big feeding vessels, then it's a good idea for you to have the coag grasper ready, because those vessels you have a very difficult time to control with snare tip. Big vessels need the coag grasper. So something to keep in mind. I hope I answered your question.
Thank you so much.
All right, any other questions? If not, then we can actually wrap it up. And I want to thank everybody. I want to thank Sriram, Sylvia, Selvi, and everyone who joined today. And also want to thank Ravi for educating me. I didn't realize Ravi from Singapore. I thought it was an oncologist. Thank you, Ravi. All right, we'll discuss the next the same patient next week. And it's a fascinating case, actually. It's a really a tough case to do, but we can discuss what to do. All right, take care. Bye-bye. Thank you.
We can't wait.
Thank
Bye-bye.
you.
Bye.
Thanks, everyone.